Oh, hey, Chris.
Hey Chuck, how are you?
I'm doing great. How are you?
I am good. It is Thanksgiving week. It's an exciting time because it's a shorter work week. I feel like my kids are very excited because they had a 2-day school week, and I hear at some school districts in the area there is no school.
It's unbelievable. It is unbelievable. I've always said, my kids go to private school. Don't get me started, but my kids do go to private schools. And the classic line absolutely applies. The more you pay, the less they go.
Well, apparently the school that my kids go to or I don't know if it's our school. I'm a little out of touch, but there's one school in the area on Monday. They have a wellness day. I don't know if it's for the teachers or for the parents or for the kids, but the Monday after Thanksgiving, on top of the short school week, they have a wellness day. So, I hope everybody's well.
Absolutely. So I want to hear about your plans. So I'm going to Alabama where my family resides and looking forward to seeing everyone. We did not go last year because of the pandemic. I'm still honestly, Alabama's not the safest place, but it's probably not that far behind Missouri. So we'll make it. What about you? What are
Well,
your
the
plans?
inside of your parents' house is probably the same as anywhere in Missouri. So, as long as you guys stay home. We are doing it here. I am on call, but I'm super excited because, as you and many of our listeners know, I love to cook and I have a whole menu plan. And I'm actually cooking some stuff now because, you never know when you're on call. But so I've already got I sat down this weekend and game planned the whole menu in terms of when to put stuff and when to get stuff going. And I'm super excited and I'm making it all. Tiffany's making a fair bit as well. And then we're doing some pies and it's super exciting.
All homemade, pies included?
No, no, no. The pies are not homemade. I am very much of the belief that if I am going to, try baking once a year, it's probably not going to end well. Just like if you tried to do some crazy case once a year, it's not going to end well. So, I'm going to leave that to the pros, but the rest of it I feel pretty comfortable doing. So we're gonna smoke some turkey legs. We're gonna use some turkey breast and a whole bunch of sides. So super excited about that.
Awesome. Enjoy every minute of it. That'll be really fun.
Will do. So we have a bit of a Thanksgiving themed episode today, but we do want to give thanks to our listeners. We had a wonderful review, and this is from Emily from Ohio, who left us a 5-star review, the only kind, of course. So this is such a great podcast. Love the humor and positive energy. Great to hear from surgeons so passionate about their careers. I'm an OT who transferred from inpatient neuro rehab to outpatient ortho and hands, constantly trying to learn and elevate my practice. This has been an entertaining and informative way to do just that. Thank you, Emily from Ohio. So, Emily, thank you for the fantastic review. We appreciate it, and we look forward to everybody letting us know how much they enjoy the podcast, or honestly, how much they don't, and what we could do better. So, email us handpodcast@gmail.com. Leave a 5-star review on iTunes. It certainly keeps us going, especially during this crazy busy time of the year.
That is well said. And Emily, thank you so much. And, I think Chris and I may be a little less, well, I'll speak for myself. I'm a little less active on Twitter. I'm just trying to keep my head above water on so many things. And we do want to hear from you. Our last episode is meant for listener feedback. That is Lauren Wessel's episode on half full, half empty. And Chris and I think, gave some controversial opinions. So shout it out if you don't agree. We want to know.
Yeah, I actually went back and listened to it. I listened to it sometimes for QI purposes, et cetera, but also to kind of know what to expect. And yeah, I'm not sure I completely agree with everything I said, but I stand by most of it. So
It's
I don't
funny.
know for
It's funny you say that because I'm sort of in the same boat. I might have phrased things differently, given a little more preparation time. But hey, whatever. We threw it out there.
Yeah, exactly. So Lauren, thank you for putting us on the hot seat. And if everybody likes it, we'd be happy to have Lauren back and do it again.
That's right.
So Chuck, interesting case. So I'm curious to what you do when. So I had a young person with a distal radius fracture recently, and it would look almost like your normal metaphyseal fracture with some intra-articular extension, and it displaced dorsally. It was acting like a standard fracture, but a younger person, um, and the split, it was almost like a split, in the lunate fossa between the volar and dorsal aspects. So more of an impaction fracture, but it wasn't acting like a volar Barton fracture where there's an actual subluxation of the carpus. the distal fragments were traveling as one, and the carpus was traveling with that distal fragment. So we get to the OR. I didn't get a pre-op CT scan, which, I didn't think it was honestly going to change my management because I probably was going to try to use a volar plate anyway. Get to the OR, do the exposure. There's some pretty substantial comminution. We get a very reasonable reduction, but we go to put a plate on, and the volar plate is just sitting a little more distal than I'm comfortable with. What do you do? Do you say, you know what, the volar plate is going to provide excellent fixation. I'll get the reduction as close as I can. I'll put the plate a little more distal than I want to, and I'll just say I'll come back and later on and remove the plate? Or do you do something else?
A couple questions. Was the plate sitting distally because the morphology of the distal radius in its best reduced position required it to be distally placed, or was the anatomy just unusual? Why did you have to put it distally? Not that I'm being critical, because certainly I've been in that same boat.
In order to get the distal row of screws reliably in the distal fragment, I had to put the plate more distal than I wanted. And that, I've checked and played around with the reduction a bit, because as George Orbe taught us, you got to get the best reduction as possible first before you start looking at putting on your plate. So I tried to get the best reduction I could, got it in neutral and maybe slightly volar tilt, got excellent length and inclination, and the plate was just sitting a little more distal than I was comfortable with. Could have gotten a little more tilt and maybe would have made the plate look a little bit better, but to really get fixation in the distal row, I needed to put the plate that distal because of the way that the fracture was splitting. The fractured line was just relatively distal on the lateral film.
And your assessment of the joint reduction was based on C-arm radiograph, not an intra-articular inspection.
Yeah, so indirect reduction from a volar approach, indirect inspection from a volar approach, yeah.
Yeah. So first of all, I agree with that approach. I will occasionally put a scope in, but that's rare because I think one can do a pretty good job of understanding the fracture pattern and the joint alignment. Maybe not perfect, but I certainly wouldn't be critical of that either. I very simplistically, I would absolutely put the plate where you have to put the plate. I would not change techniques. I would get fixation and I would get out of the OR. I would talk to the family post-op and I would say that this is what we had to do. And let's plan on removing that plate in 8, 10, 12 weeks, depending on healing, and go from there. But that would be my adjustment.
How would you rehab the patient? So would this be your standard volar plate, get them move in as early as possible? Or would this be, hey, pump the brakes, let's let the fracture heal over 6 to 8 weeks, and then go back and remove the plate and then start rehab?
Yeah, a little hard to answer. I don't know that I would necessarily immobilize for 4 weeks in a cast or something like that. I certainly wouldn't hesitate to do that because if there's any doubt in the stability of the construct, I would absolutely cast for 4 weeks and then start motion. But if I'm confident that I've secured the fracture lines and the plate is going to do its job, I would start motion. Now, having said that, it sounds like I would probably go a little slower than normal and just do some gentle active motion and get them in a splint for life purposes more than necessarily aggressive therapy purposes. I don't think you can really go wrong as long as you don't do enough to disrupt the reduction.
Is there any egregious amount of volar positioning of that plate or distal positioning of that plate that would change your strategy, saying, oh gosh, this is too prominent, this is too distal, I can't leave it this way, we got to do something else?
I don't think I've seen a plate, whether my own or as a second opinion, that's so egregious that I thought it could not have been left. I mean, certainly we're obviously talking distal to the watershed line, and by the sound of it, maybe relatively distal to the watershed line. I don't think we're going to see harm as long as that plate comes out expeditiously.
It's interesting. I saw a patient back that I had seen, gosh, like 3 or 4 years ago, and they had their distal radius fracture fixed in somewhere in the Pacific Northwest. After they were on vacation, they were hiking, had a fracture. And at the time, I was like, gosh, when I saw them in follow-up, I was like, that plate's a little distal. It's a little more distal than what I would normally put it in. But you're not having any flexor tendon irritation now. Just keep an eye on that. It's been reported to happen, 10, 15, 20 years down the line. I've seen case reports. Just, let me know. And they strolled into the clinic recently. It had been a few years since I'd seen them, to the point where it was over 3 years. So it was a quote new patient visit. And that FPL is gone. And I'm wondering, like, gosh, like, should this have been something where you move early to take it out, even if you didn't do the surgery? You're like, I don't like the way that's sitting, or do you say just keep an eye on it and we'll take care of it later? So anyway, so this case, was interesting to me because I was not comfortable leaving the plate that distal because I felt I had other options I could use. So what I ended up doing for better or worse, right or wrong, I felt this was the right thing to do. I ended up taking a 2-4 mini frag plate and tucking it along the volar intermediate column so that I could get distal enough on the fracture, but leaving it relatively contoured. So I kind of played with the plate, matched the contour of what a normal volar locking plate would be, kind of gauging them side by side, and then push it on that volar intermediate column, almost supporting the lunate facet essentially. And it allowed me to get as distal as I wanted to be without having a very prominent volar implant on the radial side where I think that FPL is more at risk. And I felt very comfortable with that, and was able to support the fracture well, get good fixation in the distal fragment, and restored the tilt to just volar to neutral. I was very satisfied with that, but I didn't know if it was worth the extra effort. It certainly was fun and educational, but it was added some time to the case.
And I'm going to say a nasty word, did you waste the volar plate?
Oh yeah, I think I did. I know, but it is of the lesser expensive types of volar plates, although that is not truly the issue. I
All
didn't feel
right.
great about it. But I also understand the cost of a return to the OR. So I felt good about how the plate was tucked. I didn't love the fact that I wasted it. I'm actually not sure because I guess some screws passed through it, but I didn't bend the plate at all. But because the plate was, screws were passed through it into the body, it probably was, quote, wasted.
Yeah. So a couple comments, maybe two for you. Um, my first comment goes back to your statement a couple minutes ago. I think we in the US look not to take out hardware in this situation. And I think we are less aggressive about doing that than other parts of the world, for sure. We've talked on this show about how I believe it's in Hong Kong where almost every plate is taken out once they put it in. So we're not looking to go there, but I just think I've been a little more aware recently because I've seen some unfortunate events like you just described with a ruptured tendon that it makes me just nervous. And so I do commit. I commit right after surgery to taking the plate back out. I talk to the patient, I talk to the family, because if I don't do it then, I know I'll be less interested in taking the plate out later. And the family typically does not forget. And I don't want to operate on patients again. I don't want to do that second surgery, but the early commitment, I think, helps me do it. Second thing is that I think you did the right thing. If you weren't comfortable with that volar plate, you have to take it out. And I obsess. I really hate doing that. I almost never do it. But it just rubs me the wrong way when I feel like I have to take out hardware that I've already put in and wasted. But it's the right thing to do. It's absolutely the right thing to do. So you made the right choice, even though I'm sure you are just as frustrated as any of us would be.
Yeah, I don't like wasting a plate. As I try to be as cost conscious as possible. But I also recognize I would not have been happy leaving that OR. And one of the things that you taught me, and many of my mentors here at WashU taught me, is that you got to leave the OR happy. Like you just can't leave unhappy and hope it works out. As one of our ortho trauma partners likes to say, hope is not a surgical strategy. You just can't, like, you have so many things under your control as a surgeon, not everything, but a lot of things. And the things that are under your control, you got to do it right.
Yep. Well said.
So, okay, let's talk about some interesting Thanksgiving stuff. So I think you're going to groan when I ask you to do this, but let's talk about 3 things I'm thankful for in my practice and 3 instruments I'm thankful for in the OR.
Why don't we go back and forth? So I'll start. 3 things I'm thankful for in my practice. The first I will say is an easy one. I am thankful for my team, and it's not. I don't know about listeners. I don't even know about you, Chris, necessarily, but I've had different medical assistants. I've had different nurses. I've been very fortunate to work with good people over the years. You and I have talked about this. What do you need from someone working with you, and what will best help you? Because what helps Chris doesn't mean it helps Chuck, and it's just all of us need something different. I'll never forget my mentor Paul Mansky. saying that he needs his assistants to be the face of personality for his clinic, and I don't need that. Anyways,
Because you have so much personality.
no, not saying that. But it's just not what I need. And it's not what I like. And so I'm really lucky to work with Nermina, who it's been, I don't know how long, 5 years, maybe, maybe not even that long. I don't know. She's fantastic. She's very much in ways similar to me. She's very directed. Patients like her probably better than they like me. She gets the job done. And this Monday, a couple things happened that made me think, wow, I really am lucky, because she not only knew what I was going to say or do before I said or did it, she was answering questions which I don't know that I could answer about my practice or my preferences. And she got it right. So, and she doesn't listen to this podcast. And I did express how grateful I was for her. But that is number one, for sure. I'm very lucky.
I would agree with you. I mean, Narina is wonderful, and she does so much stuff, and you probably shouldn't know about this, but she does a lot of stuff for our fellows that make their lives a lot easier. And she is such a resource to them. She helps them with their patients. She helps them navigate the system when they get started. And I've heard it unsolicited from multiple classes of fellows about how great Narmina specifically is. So kudos to you and Narmita for having such a great relationship. I've been fortunate in my practice, just on that note, to have Jessica with me for, I think she's actually the longest tenured MA on the service for hand, because I've had her since I started and I still remember interviewing her. So she likes to follow up. She writes things down, which always wins in my book. And I'm very thankful for that. So yes, we have great support in our clinics, a wonderful team, and honestly, without them, it'd be very difficult to get the job done. So I'm sure many of the surgeons listening feel the same way.
Yeah, and I would say for those of you who don't, there's no, I'm not perfect. I've had other medical assistants and nurses who weren't perfect, and you can make it work. But when you find that right person, it's just worth it. They are invaluable, and it just makes everything we do easier and better. So I'm not saying to give up on who you have now if they're not perfect, but work with them to try to get them there, I guess, would be one of the points. And I don't take any credit for Nermina's excellence, but wow, it's really impressive for me.
So I think the second one goes to me, and many listeners will know how strongly I feel about the therapy aspect of our practices. I'm very thankful to have the therapy team that I work with in both of my clinic settings, both at the Center for Advanced Medicine South County and in our complex nerve clinic at the main Center for Advanced Medicine in the Central West End. So that's, Kathy Dom, Jamie Findice, and Macy Stoner at those different locations. And they are an extension of our practice, even though they're not, truly integrated and affiliated with us. Patients see them as, like you were saying, kind of the personality and face of our practice. And it's become a running joke in my clinic as to how many gifts our therapists get versus how many gifts I get. It is orders of a magnitude difference, but all good. But we do have a little tally, and it's amazing to see how close patients feel with their therapy teams. I'm honored to be able to work with them, and it adds so much to my day to have them in our clinics with us, and they add so much to our evaluations and help with the integrated part of our practice.
Yeah, well said. And I don't want to sound repetitive, but you and I agree. Therapy is so important, and I'm fortunate to have really 3 different teams of therapists that I work with every week. So the first team is at the Chesterfield office, and I work with Stacy Baker, who the therapists who are listening have know her, and she's been on the has she been on the show?
No, but she and I did a ASHT pre-course together. Yeah. So maybe that's what you're thinking about.
Yeah, that must be what I'm thinking. Anyway, Stacy's unbelievable and wonderful in every way. So, and the whole Milliken hand therapy team is wonderful. I am fortunate on Tuesdays to work with Michelle and Michelle at the Shriners Hospital. They are different, from one another, but they are equally outstanding and just make everything easier at the Shrine. And then lastly, the children's group, children's hospital group I work with, Courtney and Jen are also fantastic. So I feel like I'm supported in every different direction. And more importantly than my being supported is my patients are supported and get super high level therapy. Really, really remarkable.
Yeah, they definitely, it's interesting. I've seen so many patients now for longer term follow-up now that I've been in practice longer, and I'm always impressed with how hard they work. And, at the end of the day, when everybody's happy, I thank them for all the work that they've done. And then they try to thank me, of course. And I appreciate that. But I tell them, look, I did my job on one day and seeing you back, but you and your therapist did the work week in, week out, especially for some of these bigger cases. So it is very humbling to know the amount of hours that that I will not spend with patients, but our therapists do. So
Yeah, and I just tonight I called Stacy at like right before we got on, which I don't do because I want to respect people's time away from work. But my daughter unfortunately has a stress fracture in her foot. She's a collegiate runner, and I asked Stacy if she could see her tomorrow and help make a special splint for her toe. God forbid. So Stacy's going to do it, and that's under the direction of our foot and ankle surgeon. But I mean, so remarkable.
the toe, just a dirty finger.
It is, and it's causing problems, which I don't like. um, and I guess I'm up next. So number 3, there's a lot of things that I'm thankful for. I'm thankful for my partners. I'm thankful for our department. I guess I would focus on that. There is no perfect practice setting, at least to my understanding. And we have a lot of opportunities to be better. But I like the way, I like our direction as a department. I like what we're striving for. We're definitely not there yet, but it's kind of the fight or the journey, which I'm enjoying. And so I'm grateful to be where I am doing what I'm doing.
That's well said. I'm glad that one of our department leaders is thankful for our department. That makes all of us feel better. But yeah, I think that it has been a big difference. And not to toot your horn too much, but I mean, seeing the difference that you've made since you've come into the role of executive vice chair. I've noticed a substantial difference in terms of how things are communicated, which is always appreciated at my level as being a junior attending. And I've enjoyed watching you evolve to referring to yourself in a third person on a regular basis. I mean, it even happened during hand conference a couple of weeks ago, and of course, I had to call you out on that. So it's great.
Yeah, I appreciate those kind words, including the third person reference. I don't know how that slipped out, but hey, I'll own it. I will own it.
It's okay. You don't tell Chuck Goldfarb to tell Chuck Goldfarb what to do. So so the back half I can lead off since you took the last part of 3 things you're thankful for in practice. So I will say the first instrument I'm thankful for in the OR is the Freer elevator. I love a Freer. I mean, it is such a wonderful instrument and all the various iterations of the Freer. So you've got the number 9 elevator, with the sharp little tip that Marty Boyer calls a Dingman. You've got even just like a Penfield, kind of elevator, the Kleiner Kutz, so many wonderful things that you can use a Periosto elevator for. So even more recently, I know you're going to hate to say this because you're the one who taught me how to do a carpal tunnel release, as did Ryan Calfee and Lindley Wall and our other partners. But I very much learned the Cincinnati technique of doing a carpal tunnel release. But what I love to do is to take a Freer and kind of help brush back sometimes you have those very prominent thenar muscles that lie over the TCL. I love brushing those back with a Freer after the trainee gets it started with a knife. It just kind of moves it along and then really reveals the volar aspect of the TCL. So that's one example of why I'm thankful for a Freer.
Look, I can't argue that was going to be my number 1 as well. I would focus, and I call it the K&K or the Kutz Kleinert. I don't know if it's Kleiner Kutz or Kutz Kleinert, all in reference to the Louisville hand program, which for a generation was the premier training program in the world. For those not familiar, I like the history of hand surgery, and certainly Louisville and Jewish Hospital there have really been important to many, not just in the United States. And I would say actually, especially for those who are not in the United States, it became if one was did not live in the States and was looking to advance his or her career, although let's be honest, it was mostly his career. They would do a fellowship here in Louisville, and it was a really big deal. So I love the K&K. For those of you not familiar with it, it is double-ended with different, very small tips, and it is highly effective in whatever you need us to do, almost making the incision. I love it. I will say, and I'm interested in your thought, I don't pass that instrument down very often. There's the trainee does portions of a case, and I do portions of a case, and I don't hand out that K&K very often. What about you?
I will give up the freer. I'm usually using a freer to help, honestly, to help show them how to use a freer. So, I think that's one thing that was drilled into my residency training, especially in ortho trauma with Dean Lorich, was the use of a freer and how to use it to elevate periosteal planes, and then, to help retract initially and then replace it with a Homan or a Bennett type retractor. And usually that's where it comes into play for me. And then, I will say that, for example, recently I was doing a thumb CMC arthroplasty, and we were removing the trapezium, and we were switching between using a freer and a number 9 freer and a glamry. And, obviously you're on different sides of the table, so it makes sense for one person to do one side. So it's more of an instructional kind of thing, is here's how I use this instrument. I want you to learn how to use this too, because there is a technique to it, because you got to push in a certain way, to get into the right plane without just looking like you're picking at something, which I'm sure annoys you because it annoys me.
Fair enough. Absolutely. My second choice is a Homan. There is nothing like a Homan. I use a Homan all the time. I use it for CMC arthroplasties. I use it for fractures. I think it has to be used delicately, in the sense that when you're treating a fracture, for example, an incorrectly applied Homan can make reduction harder than it should be, and you can be struggling against yourself. I think an incorrectly utilized Homan can put pressure on neurovascular structures if one is not careful. But when used correctly, it's a game changer. I'm not a big self-retainer guy. I tend to use Homans and Senrakes a lot, but I love the Homan.
Yeah, I love the Homan too. And, I will, like you're talking about placement, I will find the place for the Homan typically with a freer or another type of instrument, and then replace that freer with a Homan, because for better or worse, our sets don't have like 18 freers, which was the common trend when I was in residency, because that attending used a lot of freers. But yeah, no, I agree with you 100% on that.
All right, I've done 2 and you've done 2, so you're up for 3.
So yeah, I'm up for 3. And I'm only saying this because I know it's going to drive you bonkers, but I'm thankful for left-handed tenotomy scissors.
What?
I love them. Oh, I know that you do not like trainees to use their left hand. And I've had it happen where trainees have left my service and gone to your service, and they ask for stuff, and you're like, don't put that in your left hand if they're right hand dominant. But I love it because, for better or worse, I had a metacarpal fracture when I was in medical school, and no, I did not punch anybody. But I had to learn to do a lot of stuff with my left hand, including shaving, brushing teeth, and all that kind of stuff, and even some basic penmanship. And even at the relatively older age of medical school, I think that helped me a lot, because my left hand developed at a time where I kind of needed it to develop. And then, during residency, having to put drill and put screws in all sorts of odd angles on the trauma service, I learned to use my left hand. And now I will even dissect with my left hand because it is easier with the left-handed tenotomy scissor.
That is stunning. So a couple of minutes ago, you shared that you might do part of a surgery and the trainee might do part of a surgery based on where you're sitting in reference to what needed to be done. And I had this conversation with 2 trainees today. I strongly feel that is the best approach, which for me obviates the need for left-handed scissors, because I'm going to do my side in my direction. They're going to do their side in their direction, obviously under close supervision. I don't know why you would want to use your lesser hand when there are other options available, including turning your body.
What if your lesser hand was just as good, Chuck? Just to give you that option. So I will say, but there are, I'm not the executive vice chair. There are times where I don't have a trainee. And you got to do the case. And say, for example, you're sitting on you're doing a left ulnar, you're doing a left-sided ulnar nerve transposition, and you're sitting in the axilla to do the dissection. I'm not going to go to the other side of the table so I can use my right hand. And when you're relatively proximal, it is super awkward and looks even worse to me when you completely turn your body to use your right hand in that dissection. So I feel confident in my ability to use a tenotomy scissor in my left hand. It's taken some practice, but I feel like I've gotten pretty good at it. And then in the nerve stuff, sometimes you are dissecting in a very weird angle. And the best place to see is where you would use your left hand, and you just kind of have to use your left hand. Now, I admit that sometimes there are times where I don't quite have the angle, and I'll actually use a tenotomy or a Burlington / Adson to spread the plane and then cut with my right hand over that instrument. But usually, it all depends on the tissue planes and what I can see at the time and how I feel the most comfortable.
So let me make sure I understand, because I don't want you labeled inappropriately as high maintenance. On your Mayo stand, do you always have both right and left-handed tenotomies available?
No, they're peel packed. They're in the room. They're peel packed, but they are specifically left-handed because obviously the blades have to converge in a certain way to be used in your left hand. And unlike all those lefties out there, I never learned how to use right-handed scissors in my left hand. So I'm sure that the lefties out there are like, you don't need those, but for the righties out there, you do have to use them. And I find it incredibly useful. It speeds my case along, and for me, it's been a game changer.
To each his or her own.
I knew that was the response I would get. I love it.
I will close it. And some of you listeners will appreciate this and some will not. I love a good heavy mallet and osteotome. I am an orthopedic surgeon, and there are times when pounding with an osteotome and mallet feels really good. And when a mallet has a plastic side and a metal side, I get angry when the resident or fellow wants to use the plastic side. I want metal striking metal in a very orthopedic way sometimes.
How often are you using a mallet? Like, I can think of the number of times I use a mallet, and, like, I guess if I'm removing a plate and it's hard to kind of get that plane and I want to open it up, or if I'm maybe splitting the trapezium, if we can't get the trapezium out piecemeal, when the hell are you using a mallet?
Regularly. I probably had 3 or 4 cases last week. So osteotomies, when I do an osteotomy,
Okay.
I always perforate the cortex. I don't use a saw, perforate with a K-wire and then use the mallet. So there's a couple of those last week. Whenever
Distal
I
radius,
can.
like when you're doing cancellous autograft or something like that, and you're opening a window, do you use a mallet then, or?
Actually, I don't. I just use a curette like a drill. But I like the mallet. Feels good.
That's like total hand weenie orthopedic inferiority complex 101 right there. So, hey, great. Guys, if you're listening, guys and gals, if you're listening, get Chuck the biggest mallet you can find. I've seen some monster mallets on Twitter, and clearly our hand surgeon needs one of those.
It makes me feel good. Just roll with it.
Well, that was fun. I hope everybody has a wonderful and safe and happy Thanksgiving. I hope everybody eats as much as I am going to this weekend and enjoys it thoroughly.
Absolutely. Enjoy your meal, and I look forward to next time.
All right. Have a good time in Alabama. Talk to you soon.
Thank you.